Welcome, everybody, and thanks for joining us. We're really excited to bring you this special webinar specifically on a topic that our region leads thought would be of interest to everybody. Lots of people have questions about nephrology and HPP. So tonight we bring you the impact of hypophosphatasia on the kidneys. And before I introduce our guest speakers tonight, I have a few housekeeping notes. One is we would like to thank our sponsor, Alexion. This program is brought to us in part by support from Alexion Pharmaceuticals, and we're really grateful for their support. From a housekeeping perspective, everybody should be muted just to make sure that sound quality is optimized. Familiarize yourself with Zoom. You'll see at the bottom of your page there is an unmute button, also operations controls for you to be able to turn your camera on and off. And at the end of the presentation, after the Q&A, we're going to separate everybody into breakout rooms based on region, and your region leads are sitting by patiently waiting for you there. And so when you are prompted to, you'll have to accept. There'll be a small button on your screen that'll pop up to accept and be admitted into that room. And then you'll have to unmute yourself and turn your camera on if you want to be able to talk. Any questions that you have during the webinar, if you can use the chat window, which is also in that bottom navigation bar, and you can send those chat messages directly to me. So without further ado, I'm going to introduce our speakers. Dr. Rosa Yube is a pediatric nephrologist in Huntington, West Virginia, where she specializes in pediatric nephrology. She's a widely published author in dozens of medical journals, and Dr. Yube graduated from West Virginia University School of Medicine, and she formerly worked in Columbus, Ohio at Nationwide Children's Hospital, where she learned about hypophosphatasia working alongside her colleague, Dr. John Mann. Dr. John Mann is a professor of pediatrics in the Division of Nephrology and Hypertension at the Nationwide Children's Hospital and The Ohio State University College of Medicine. He is also director of the Nationwide Children's Center for Faculty Development and program director of the Pediatric Nephrology Fellowship Program. Dr. Mann received his medical degree from Hahnemann Medical College, which is now Drexel University. His clinical and research interests include pediatric dialysis, renal transplantation, growth failure in children with chronic kidney disease, and emerging therapies for metabolic bone disorders in children. He's also a member of the board and the medical advisory board of the National Kidney Foundation, serving Ohio, Kentucky, and Tennessee. So first I want to thank you both for joining us and being willing to take time out of your busy schedules to talk to us about hypophosphatasia. So I'm going to turn it over to you.
Of course. Well, thank you for that introduction, and I want to thank you for the invitation. It's my pleasure, and really appreciate Dr. Mann bringing me along for be able to speak to you guys tonight. Let's see, let's try this. It's taken about a year's worth of practice, but I think I finally somewhat mastered Zoom. Hopefully everybody can see that. Okay.
Yes.
So we'll get started tonight. We're going to talk about hypophosphatasia, of course, and how it affects the kidney. So again, we'll just kind of review some basic tenets of HPP or hypophosphatasia. Look at hypophosphatasia in the kidneys. Kind of review, promoting what is the best way to help bones grow, to be healthy, and the best way to protect and have long-term kidney health. Also, we're going to look for what to look for or ask about for your child and their kidneys when it comes to hypophosphatasia. Now, we know that hypophosphatasia, it's a rare inherited metabolic disorder. It's caused by a loss of function mutation in an ALPL gene, which is the alkaline phosphatase. Now, the prevalence we know is about 1 in 6,000 individuals, and incidence or new patients is about 500 to 600 new patients per year in the US population. Now, the importance is this gene, the ALPL gene, encodes a very specific mineralization enzyme called the TNSLP. So we have a long history of kind of naming these these enzymes, and that stands for tissue non-specific alkaline phosphatase. Now, the importance of that is in bone, it generates phosphorus to be incorporated into bone mineral crystals. So we talk about building strong and healthy bones, and I always use the analogy, it's kind of like building a house. To do that, you need the right bricks and mortar and stone, and to build healthy bones, you need calcium and phosphorus and vitamin D. So this mineralization enzyme, the TNSLP, is highly expressed, so we find it in the liver, the kidney, as well as bone. Now, if you have a deficiency in this enzyme, the TNSLP again, now that means that that enzyme isn't able to do its correct job or its function. And so it leads to extracellular accumulation of substrates in tissues. So basically what that means is all these kind of toxic substrates that should be incorporated into bone and should be metabolized aren't able to do so properly. They're kind of hanging out in the wrong places. Again, we know this is an inherited disorder. It can be autosomal dominant or recessive forms. Now, the interesting thing is the clinical presentation does vary between individuals, and even within one individual, some of the clinical presentation can change. Even within one family, there's different clinical presentations. Now, historically, the way we kind of classify HPP was based on the age at which it manifests. Now, regardless of age, the odonto form, which is we see premature loss of deciduous teeth, that's usually across the board what people find. And again, that can be at any age of presentation. We look at the different forms. So we have some perinatal forms that are usually found, so the time of onset is during the fetal period. Now there's a perinatal, very severe form that we see, which is severe bone hypomineralization. So the bone never forms properly. The cranium or the skull never completely forms either, and it's almost just like a membrane. There's no kind of hard shell there. These patients often have respiratory disorders, vitamin B6 dependent seizures or convulsions, and early death without treatment. Now, there's also, interestingly, at the same time, it's perinatal form that you see in the fetal period. It can be completely benign. They just have long bones, and they have a much more favorable, lifelong prognosis. Now, the infantile form, so we kind of classify this as before 6 months and after birth. So the first 6 months, we should say, they typically present, and this is kind of a bread and butter with pediatrics, is failure to thrive, which is an umbrella term, of course, but we always have to look at multiple reasons that could be. These patients have rickets-like bone changes, which is very important because they can present like a hypophosphatemic or vitamin D dependent rickets. And it's very important for clinicians and everybody to know that this diagnosis can be a possibility and what to look for. These patients often present with hypercalcemia, and because of that high calcium in the blood, the kidneys, I always say the kidneys are the smartest organs in the world, and they say we got to get rid of that extra calcium, and so you pee it out in the urine, and so you have hypercalceuria. You can have premature craniosynostosis, which just means that abnormal kind of formation, the way that the skull and those soft bones form, could be in different shapes, or they close too quickly. Now, approximately 50% of these patients will have respiratory complications that may ultimately lead to death if they're not properly treated. Okay. Now, we look at this classic age here. So childhood, we say 6 months to less than 18 years, and then adults or anything after 18 years. Again, in childhood, we look for these premature loss of the deciduous teeth. Again, ricket-like bone changes. And it's important, again, that clinicians also be familiar with this so we don't misdiagnose these guys as just having a low vitamin D or hypophosphatemic rickets. They often have gait abnormalities, so ambulation problems, and then can lead to fractures. But they do have a more favorable life prognosis. Adults after 18 years, again, they can have dental symptoms. They can have these fractures or pseudo fractures, but they do have low bone density. And low muscle strength. They've never really had the appropriate kind of weight bearing to be able to develop that type of strength. They may have myalgia or arthralgia, which just means kind of pain in the muscles or joints. Headaches, pseudo-gout. Again, no more of a favorable life prognosis. Alrighty, now when we look at kind of these HPP or hypophosphatasia related manifestations, it really was looking at the overall kind of the clinical burden for patients and for looking for clinicians of HPP. So again, you have premature loss of those primary or deciduous teeth. The cranial abnormalities that we talked about, so cranial synostosis, frontal bossing, so basically just that kind of outward of the frontal bone, a large anterior fontanelle. You can see decreased skull ossification. So again, we all talk about baby soft spots that eventually kind of ossify or the skull forms, but you may see that in an abnormal pattern. Also, that could lead to increased intracranial pressure, so higher pressure within the skull, causing issues in and of itself. Now, again, these patients can have gross motor or trouble ambulating, so difficulty walking, gait disturbances, needed for motility devices, so wheelchairs, or any other mobility impacts. So, and again, it can affect the way people in children, again, running, playing, development, the way patients are able to work or in kind of impairment, just the daily activity of their lives. Now, you have a lot of surgical issues that can pop up. Again, you can have any extremity with the fractures. Some of these cranial synostosis, if there's issues there, may lead to cranial surgeries, dental issues, and kind of spinal issues as well. So any of those from an orthopedic standpoint may lead to problems. Other dental issues, again, other than the premature loss, you can have any abnormalities in the formation of a dentition, severe periodontitis, and atrophy of these little alveolar ridges within the dentition itself. Fractures we talk about, you can have stress fractures, bone fractures, and not just fractures. We talk about high impact, or if somebody falls off the roof of a house, you expect somebody to fracture, but we're talking about very kind of minor non-traumatic fractures that can happen in patients. And then pain, just generalized muscle pain, joint pain, or bone pain. In addition to like surgeries and other issues that we may have, just kind of the treatment for those may involve a lot of NSAIDs or other medications for pain. Respiratory symptoms, so there's often respiratory compromise. There can be pulmonary hypoplasia, so that means the lungs don't fully develop. And again, you look back at those the fetal presentation, and some of those patients, the high mortality comes from respiratory complications. It's because of the lungs don't form properly. Can have recurrent respiratory tract infections and need for respiratory support, maybe even the need for a tracheostomy, so things like that to help patients breathe. And again, that requires a lot of hospitalizations, possible surgeries, and complications from there. Now, what we are going to talk about, of course, are kidney complications, which we'll talk about nephrocalcinosis, which basically means a lot of calcium deposition in the kidney. That can also lead to kidney stones. And then renal insufficiency, which can be from many different causes, including the nephrocalcinosis and buildup. And also, which Dr. Mann will get into as well, but some of the treatments that we have, so a lot of NSAIDs, so chronic use of NSAIDs along with the calcium stones can lead to renal insufficiency. Other complications, just looking at just overall anxiety, depression, insomnia from a psychological standpoint. And we'd mentioned earlier about seizures. They could be vitamin B6 responsive, so they're deficient in that vitamin. Or you could have seizures of unknown origin, but can lead to some significant neurologic complications. Now, treatments, traditional treatments. And again, these therapies, what we know or thought were the best things to use at the time. So symptomatic, we give patients extra calcium or extra vitamin D, right? We think healthy bones. Remember, I referred earlier to calcium, phosphorus, and vitamin D. How do we build bones? And again, that's why I lead back to it's very important. These patients may just appear like they have a low vitamin D or hypophosphatemic rickets, and they're given extra calcium or vitamin D for that reason, but this may lead to some complications, and the therapy itself can lead to some of these renal complications. Again, in an earlier slide, remember I said that patients often have a high hypercalcemia, which is a high blood level of calcium, and high level of calcium in the urine, which can be exacerbated by some of these traditional therapies. And then, of course, the enzyme replacement, which has been around since 2015. Remember, that's that bone-targeted recombinant human, the alpha-alphatase alpha. Again, so if the gene is defective, we're trying to do gene replacement. And which is allow, again, if you replace the enzyme, kind of more normal cellular activity and more normal mineralization activity from the very beginning. Okay. Dr. Mann, I think this is where you start.
Okay, thank you, Rose. So
Thank you.
I had the great pleasure of having Rose be one of our stellar fellows, and she ended up joining our faculty. And one of her areas of interest was this whole issue of medical bone disease in a variety of different disorders. And one of the challenging disorders that we've seen over the years are the patients with HPP. Often, as some of you know, the diagnosis is delayed. Oftentimes, there have been good-natured attempts to promote better bone health by giving extra vitamin D and calcium, as Rose mentioned. And unfortunately, we think some of the kidney issues that our patients suffer from are really related to these good intention efforts. When we look at the issue of kidney complications in patients with HPP, it really is an area that is understudied. I'll share with you a little bit of information and share with you a little bit of what we've seen in our patients, but it really impresses me that I think we're really looking at the tip of the iceberg in our patients. However, at the same time, with the advent of enzyme replacement therapy, I think we could look to having better kidney health in our patients in the future because of the more directed therapy and avoiding some of the potential problems. So for example, on this slide over here, this is actually an extreme example of nephrocalcinosis or calcium deposits in the kidney showing up on an MRI. You can see the white dense spots lining both kidneys. Here's what the kidneys would look like in a diagram, but this is really a dangerous situation for a patient, and it can be relatively silent with no pain while this is developing, but it's not hard to imagine that this can lead to kidney damage as those calcium deposits continue to grow, and also symptomatic kidney stone issues as well. So when we talk about the nephrocalcinosis and kidney stones, that has been sort of the most commonly observed problem in patients with HPP, and presenting with kidney pain or burning or pain with urination, or sometimes just with blood in the urine in a patient who's otherwise asymptomatic. One of the problems with nephrocalcinosis and damage to the kidneys is leading to chronic kidney damage or chronic kidney disease. We also know that certain medications like the non-steroidal anti-inflammatory agents like ibuprofen, if given for a long period of time and in high doses, can also lead to independently driven damage to the kidneys. So we think some of the individuals that develop chronic kidney disease are experiencing this because of the impact of the medications like the non-steroidal anti-inflammatory agents. And then we also know that some of our patients, again, partly we think related to treatment, but partly because of declining kidney function, will develop high levels of serum phosphorus or high levels of serum calcium, or both, which can lead to further damage and sort of set up a vicious cycle of high levels of calcium and phosphorus, kidney damage, higher levels of those compounds, and continued injury, which may or may not be made worse by the development of high blood pressure.
Dr. Mann, I think you're muted. Yeah.
Let's try that again.
There you go.
So
Yep.
when we see these kidney complications, in reviewing the literature, the prevalence or how frequent these things happen and the incidence or how often they come up in patients as a new problem is really not well defined. There's really not good population information. Recently, we went back and looked at 10 children that we diagnosed with HPP in the last 5 years. And we looked at kidney symptoms. We looked at presence of abnormal urinalysis. We looked at things like kidney stones, nephrocalcinosis, and the evidence of kidney disease. And for these children, they did not have any kidney symptoms. So there was no signs of kidney involvement. In the patients that had urinalyses, only one of those 10 children had evidence of blood in the urine that would suggest something going on with calcium crystals or other problems. We had done ultrasounds in 5 of those 10 kids, and none of those ultrasounds showed any nephrocalcinosis. But I will also tell you that none of these kids were on extra vitamin D, and none of these kids had high blood calcium levels. So I think some of the fact that we're not seeing calcium deposits is because we really moved away from giving these kids excessive amounts of calcium and vitamin D. And luckily, none of these kids at this point have evidence of chronic kidney disease. Next slide, Rose. So when we think about kidney complications and management, we really talk about trying to detect early and minimize the development of nephrocalcinosis and kidney stones, trying to avoid the development of chronic kidney disease, and trying to make sure that high levels of serum phosphorus and calcium do not develop. So what a patient with nephrocalcinosis would typically have concerns about nephrocalcinosis result because of seeing blood in the urine or seeing abnormal levels of phosphorus or calcium in the blood. And ultimately, it's really an ultrasound diagnosis. You need to do an ultrasound to find that. And if there is nephrocalcinosis, then really particular attention to high fluid intake and to do other things to minimize the buildup of calcium in the urine would be employed. If a patient has chronic kidney disease, that's going to typically be diagnosed by blood test and suggested by urine test. And that really should involve getting a nephrologist involved to try to employ preventive strategies and things like controlling blood pressure and other monitoring that's so important. And then lastly, seeing a high serum phosphorus or high serum calcium. A patient with HPP, we would really expect that those things should be monitored periodically to make sure that they're not developing in a silent fashion. And then if they would develop high levels of calcium or phosphorus, we'd really be talking about getting an endocrinologist or a nephrologist involved to manage that. And then to look at things like vitamin D and PTH and to potentially adjust diet and do other things like that. So in a recent large series that was published in 2019, this was a study of 265 patients that were accumulated in different reports in the literature. And nephrocalcinosis was present in about 5% of these patients. So again, not everyone had ultrasounds. So that 5% we believe is really the tip of the iceberg. There's probably a higher percentage than 5%. And when in these 265 patients, when the presence of chronic kidney disease was tested for, which was not everybody, we saw that about 1.5% to 2% of the patients had evidence of kidney damage at this point. And some of these were young kids, some of these were adults. And then levels of high serum phosphorus and high serum calcium were not really reported in this study. So we think that some of those patients are going to have high levels of serum calcium or serum phosphorus in the blood as sort of an early sign that they're getting into trouble, but this has not really been reported on. So basically, we don't have good data on how frequent these problems are. And I think as we would move forward, Rose, you hit the next slide, we would really think about what patients and families can do to preserve bone and kidney health because they are so very related. So one thing is good fluid intake. Having good fluid intake, preferably water, will help flush out any high levels of calcium or phosphorus in the urine and minimize the chances of those depositing in the kidney. We want our patients to get normal calcium intake. Low calcium intake actually puts the bones at more risk and is not healthy. So what we're talking about is 2 to 3 dairy products a day. And then for patients that are not willing or able to take in dairy products, sometimes there's milk allergies or lactose intolerance, then it is important that those individuals get calcium, because you do need a normal amount of calcium. So we talk about calcium supplements to take the place of 2 to 3 dairy products a day if the individual patient's not able to do that. We want normal vitamin D levels, not high, but at the same time, low vitamin D levels are going to make the bone demineralization, the risk of bone pain and fractures greater. So we think getting vitamin D levels measured yearly, and to make sure that patients are getting enough vitamin D to maintain a 25 D level between 30 and 50 nanograms per milliliter is best practice. We also think patients with HPP should have regular kidney assessments. They should have their blood pressure measured every year. They should have a urinalysis done every year. And serum creatinine should be measured at least periodically, and ideally once a year, to make sure that kidney function is not slowly and insidiously being compromised by the different therapies and issues of HPP. And then lastly, in terms of preserving bone and kidney health, we talk about regular monitoring of bone status. So for example, getting a bone density test, and then measuring things like PTH and vitamin D to make sure that these are staying normal. There's not formal recommendations to get a bone density test yearly, but a patient with HPP is at risk for osteopenia and osteoporosis, low bone mass. So that really should be entered into the thinking about being done periodically in these patients. And then if we see a patient with HPP is beginning to lose bone mass or not gain bone mass in a child as they should, then this would really suggest increasing monitoring and increasing therapy. And in some patients may be an indication to move on to enzyme replacement therapy. So this is kind of where we end up in our thinking about preserving kidney health by really also preserving bone health in patients with HPP. And we really think in terms of that kidney bone axis as being part of the way we think about monitoring and managing our patients. So I believe at that we're open to taking questions, Deb, and we'd love to kind of hear what our patients and families that are attending have in terms of questions. Rose and I are going to work with Soft Bones to develop a kidney flyer handout similar to what's been developed for the ocular ones, so that we'll be able to put all of this into a single document that will be on your website that you'll be able to download. And we think that although we can do dialysis, we really don't want to do dialysis. So we're all about preventing patients from getting kidney damage and kidney problems. So it's all about prevention from our standpoint, and we'd love to help patients in that regard.
Absolutely.
Great. Well, that was so informative. Thank you so much for the presentation and the very thorough overview. I think you answered a lot of questions that I've had just in your presentation, but we did get a few questions that came in. One question was just about whether you are ever on the front lines of diagnosis of HPP. Do you ever see patients who have kidney issues and maybe you're one of the first people to realize that it's connected to HPP?
Well, let me handle this one, Rose, because
Sure.
I think typically it's amazing how late HPP patients get diagnosed, and you all know that, I'm sure, in your own families, in your own lives. But I would say by far and away, the reason HPP patients get diagnosed is because of bone complaints and dental problems, not kidney. So I can't think of a patient where nephrocalcinosis or blood in the urine was the first sign. There was typically bone and dental issues that sort of got them to our attention first.
Okay. A second question that came in that you mentioned hypophosphatemia or high serum phosphorus, but this particular patient who has HPP and hyperparathyroidism was also diagnosed with low phosphate, hypophosphatemia. So was wondering if you've ever heard of this or would you recommend any additional testing?
So sometimes that can be a secondary cause, but the etiology is kind of very important when you're looking at those things. Patients with HPP typically present with kind of a high, like a rickets-like presentation, but a high serum calcium, and the PTH is typically normal. John, do you recommend any other testing or?
Yeah, I would wonder if that hyperparathyroidism, that high PTH leading to low phosphorus, could have been related to either low vitamin D.
Yeah.
Because with low vitamin D levels, you will reach a point where you'll start spilling phosphorus in the urine, and the PTH will be elevated, trying to maintain a normal serum calcium. So I would worry about low vitamin D levels as a possibility. And then, as Rose said, hyperparathyroidism by itself is not a part of HPP. So I would worry about the possibility of having two disorders, which would be really bad luck. But we have to recognize that sometimes when things don't fit a sort of classic pattern, it's because there are two problems going on. So I would rule out vitamin D deficiency first. And then in the absence of that, think about the possibility of two different, actually a second condition, second problem.
Great.
Hey, Deb, I'd just like to remind people to ask questions to you. I know they're coming over here to me as the host on admin, but if you could ask questions to Deborah directly, she's picking them up there. Thank you.
Okay, great. We do have another question about, a lot of patients take NSAIDs to help to manage the inflammation and pain, and I just wanted you to reiterate, the impact and what should we be concerned about or looking for when we're relying on NSAIDs to manage pain.
So, with any kind of kidney issue, kind of worry about long-term NSAIDs. So the biggest thing is, are there other ways to manage pain when we talk about, the proper intake of calcium and phos and vitamin D, preventing fractures? Chronic NSAID use, especially if you're looking at patients who aren't staying well hydrated, if they have other issues with their kidney or kidney stones, those are the ones that are at highest risk long term. So we can minimize that by kind of taking care of some of the issues that cause pain, again, with kind of preventative strategies and healthy bone, maintaining really good hydration and trying to prevent kidney stones and infections and high blood pressure. It's a combination of those things long term that really kind of lead to decline in renal function.
Yeah, I agree, Deb. I think anyone that is taking NSAIDs 2, 3, 4 times a day, over time is really increasing the risk of kidney damage and kidney problems. And you take what you need to take, but I would really sit down with your doctor and talk about what alternatives do you have. And we're certainly not suggesting opioids are a great alternative.
No,
but sometimes enzyme replacement therapy, that may be the sign that you need to try that. Now, we've had several of our adults, parents of our kids with HPP, where when they got on enzyme replacement, they were able to cut back on their pain med usage. It's pretty impressive. And these are folks that were taking a lot of pain meds just to get through life, So I go back to minimizing as much as possible, but certainly a big piece, if you are taking NSAIDs, is to remain well hydrated.
Yeah.
That's a big piece.
Okay. Here's another question. Are there dangers of having untreated hypercalceuria, and could kidney involvement be an indication to treat with enzyme replacement therapy, especially when dealing with a pediatric case?
Absolutely. So the hypercalceuria long-term leads to the nephrocalcinosis and kidney stones, right? And so one of the other things Dr. Mann talked about was looking at other risk factors for stones, and there are different urine tests and things that we can look at, but that's absolutely could be an indication. So there are ways to treat high urine calcium with different things like thiazide, diuretics, but again, it's leaching, that calcium is leaching at a bone, and again, depositing in the kidneys, and that may be a real issue long term. And instead of adding, tons of additional medications and treatments, which again may be helpful in the short term, is there something with enzyme replacement that we can help that calcium again mineralize better? So.
Okay.
Yeah, and Deb, I think the way we think of it is the poor kidneys, they're innocent bystanders here.
That's right.
I mean, they're really not doing anything wrong, but they're being assaulted by all this calcium and phosphorus that ought to go into bone and ought to be done, used in healthy cells. So I think it's exciting when you can think about, doing better mineralization by having the tissue non-specific alkaline phosphatase do what it's supposed to do.
Yes.
So yeah, if I had a patient where we could not get the hypercalceuria under control, that would really push me to do more aggressive treatments like enzyme replacement and much more sort of intentional management of calcium intake, vitamin D status, and so on.
It makes a lot of sense. What about patients who aren't on therapy? What kind of maintenance should they be looking at in terms of getting ultrasounds? What kind of cadence should they be in terms of getting those types of tests?
Yeah, well, the recent recommendations were to look at kidney status yearly with doing a urinalysis, a blood pressure, and an ultrasound. There was not specific recommendations about doing creatinine yearly, but because creatinine will be sort of a later, like starting to lose kidney function will be a later finding. So I think getting a urinalysis, a blood pressure, and a renal ultrasound yearly is just good health maintenance for a patient with HPP where we know the kidneys are at risk. And then whether you do a creatinine once a year or do it less frequently, but do it periodically would make sense as well.
Yep, absolutely.
Okay, so there's another question relating to Dexa scans. Can you have a normal Dexa with HPP? Doctors wonder how mine can be normal for my age. Not sure what to say in response. And can you explain phosphorus and calcium being spilled into the urine, but normal serum levels?
Yeah. Well, let me do the Dexa question, and I'll let Dr. Ayu talk about the urine levels. So in terms of the Dexa just says how much calcium and phosphorus is in bone, because the major bone minerals are calcium and phosphorus. So a normal Dexa does not mean your bones are normal, okay? But an abnormal Dexa, a low Dexa, means your bones are really not normal. So when we look at our patients with HPP, we see a lot of them have normal Dexa, but they still end up having bone pain and fractures. So I try to make sure people understand that a normal Dexa doesn't mean everything's fine. But the reason we do it is if it's low, then you're really getting into significant problem kind of position. So I would say for the patient who has a normal Dexa with HPP, that's great. I mean, that's good, but you still have to do everything you can to maintain normal bone health and not let that Dexa become low over time. So Rose, why don't you talk about the urine levels, because that is perplexing to people how the levels can be high.
Yeah, the urine calcium and phos sometimes, and it's more the urine calcium that we've noted, but the high calcium in the serum and sometimes the blood, as usually is like in the younger patients and can present like that. But a lot of times when we see it later, it's because of some of these treatments. So we're just getting rid of that extra calcium, the things that have been absorbed in the gut. And as the kidneys weigh, like Dr. Mann said, it's getting assaulted with extra calcium or the vitamin D that makes kind of your gut and your bone increase calcium and phosphorus. And it's just a way that it kind of gets out of this system. The mechanism with some of that involvement with the kidney hasn't been elucidated real well with HPP. But like any stone former, you have a little bit of extra calcium and phosphorus in the urine, then that's all that it needs to kind of hang out together and to kind of form those stones. So it doesn't always have to be real high serum levels. It can be just excess, whether it's diet or extra vitamin D, that are kind of causing the kidney to eliminate what's extra with those. But that's more common than the high serum levels, honestly.
Yeah, in that sense, Deb, really the urine levels are high because the kidney's trying to filter out, and for a while it'll maintain the normal blood levels at the expense of dumping a lot in the urine, which again leads to calcium deposits and kidney stones. So really high levels in the urine are really a sign that we need to up our efforts to try to get rid of these minerals and minimize buildup of these minerals so we don't develop the high blood levels.
That makes sense. Is there any relationship between high blood pressure and kidney issues? Somebody says, I'm 53 and it's just now becoming high.
Yeah, well, the problem with high blood pressure and kidney disease is they are inevitably linked. So when you get kidney damage, that tends to raise the blood pressure because there are molecules secreted by the kidney, in particular renin, that will be released into the bloodstream that will raise the blood pressure. And then when you get high blood pressure, one of the first things that develops is damage to the blood vessels in the kidney, which cause kidney damage and further high blood pressure. So there's again, a vicious cycle that occurs all too often. Unfortunately, you can have high blood pressure from other causes besides HPP, but it can make the kidney damage seen in HPP worse. So we certainly see individuals in our industrialized countries that develop high blood pressure because of a family tendency to have high blood pressure. Some cases they develop high blood pressure because of things like obesity, which increases the blood pressure. And then sometimes they can develop high blood pressure because of slow, silent kidney damage. So we can imagine some of our HPP patients may have some high blood pressure from the HPP, but they may have it from things like a family tendency or obesity. So it becomes a multi-factor or multiple cause kind of problem. What's so critical, and us kidney doctors will repeat this over and over and over, is to control the blood pressure. Studies show that if you've got kidney disease and you develop high blood pressure, that is the pathway to further progressive kidney damage. And blood pressure, we have 8 different types of medications to control blood pressure. There's a reason for that because every patient's different. And kidney doctors working with a primary care doc will find the right combination of medications. But what's so crucial if you have high blood pressure is to control it so that you don't develop progressive kidney damage.
Understood. More questions coming in. Is eGFR, the blood test, sufficient to gauge kidney health, or is there another blood test involving cystatin?
Yeah, that's an excellent question. I know there's a ringer nephrologist out there asking it, but so the way we estimate GFR, glomerular filtration rate, that's kind of how we look at the function of the kidney. And it's inversely related to when we talk about the blood test creatinine. So as the creatinine goes up, the estimated GFR goes down. Creatinine, is a product of muscle mass and muscle. So obviously, children, adults, males and females will have different creatinine levels. If you have a low muscle mass, the creatinine can kind of overestimate renal function. Now, it's the best marker that we have that can be done, an outpatient blood test and not hooked up in a lab somewhere for 24-hour monitoring. But cystatin C has actually been very useful in patients over the age of a year. It's produced kind of equally among men, women, children. And so we use it, we plug it into one of our famous equations. So the best way to look at kidney disease is kind of a combination of creatinine and cystatin C to get a better idea of what our function is. Creatinine is obviously useful, and but as Dr. Mann kind of alluded to earlier, is sometimes the horse is already out of the barn. By the time we see injury, the creatinine may be delayed a little bit, especially acutely. But with cystatin C and using that combination, we get a much better estimate of renal function.
Thank you. We have 2 more questions. One is, I understand why supplemental calcium could be damaging, but did I hear that additional vitamin D can also be damaging? Doesn't vitamin D help to absorb calcium? So wouldn't more vitamin D be efficacious?
Yeah, so good question, Deb. And I think, again, before we had enzyme replacement, the idea was let's make sure we get as much calcium and vitamin D so that the bones will do as good as possible. And normal vitamin D is essential for bone health. Mm-hmm. But I think the problem is sometimes people did a little bit more than necessary. And part of it was well-intentioned. People were trying to do the best they could for the bones. But what we've learned is that vitamin D helps absorb calcium in the gut. And if the calcium doesn't go into the bone, it's got to go somewhere. It goes out through the kidneys. And we think that was causing some of this nephrocalcinosis and chronic kidney disease. So what we really strive for nowadays is to have a normal vitamin D level, ideally between 30 and 50, and have normal calcium intake. So the idea is not to do high levels of calcium intake, not to have high levels of vitamin D, but to really keep them in the normal range. And by that, you'll minimize the injury to the kidneys that would occur from having high levels.
What about vitamin K2?
Oh, interesting question. So vitamin K is very important in blood clotting. It also is involved in bone proteins. So some of the bone proteins that are important as the substructure that gets mineralized are actually vitamin K dependent. Vitamin K is important in the formation of these proteins. So we want to see normal vitamin K levels. Most people in a Western kind of civilization in our diets have normal vitamin K levels from our normal dietary intake, but it would only be in people that are on very unusual diets. So I think if you're on any kind of very restricted diet or unusual diet, you should talk about that with your physician, your healthcare provider, and make sure that your sources of vitamin K are appropriate. And then, it may be that from a multivitamin would be a way to make sure that you're getting good vitamin K.
With patients who are on enzyme replacement therapy, a lot of times their ALP levels are extremely high when you take blood work. And so there's a question from a patient about, with the enzyme replacement therapy, does the ALP have to be so high? And, is there any risk to that? And then there's a part B to that question, which is somewhat unrelated. Would the symptoms of a person developing antibodies to an enzyme, would there be any kidney manifestation to that?
Good questions. Good questions. So, yeah. So in terms of I'll let you take the second question, Rose. But in terms of the first question, the enzyme level, and is there any danger to that? I think this is an area that is still evolving. In terms of when these clinical trials are done. They're done well, but they're only the beginning of us understanding what's the best way to manage these issues with our patients. So I think initially the studies were done in a way to make sure that there was enough enzymes so that mineralization of bone and activity of alkaline phosphatase inside cells was as normal as possible. And I think over time we'll get wiser in terms of what's the best targets and whether certain levels may be better or worse. So right now, I think I would follow what the sort of initial clinical trials found with the alphatase replacement dosing. But we'll continue as healthcare professionals to look at dose response and look at outcomes and look to see whether certain levels of enzyme and alkaline phosphatase are associated with better outcomes or not.
And that's a great question.
Kind of an area of continue to stay tuned. Yeah.
Especially,
so Rose, how about this question of if you develop antibodies, whether that could be a problem?
That's a great question, and kind of going on with the clinical guidelines. Yeah, absolutely. And anytime the body, if it develops antibodies, you'll see that the drug doesn't work, that you're not kind of hitting those target levels. And sometimes with there's development of antibodies, especially look at kidney involvement, it can deposit in the kidney and cause different kind of reactions from the body from that standpoint. But again, that can be, I don't know that it's ever been reported yet with this enzyme that I'm aware of, but the body can absolutely develop antibody to anything that it's seen as foreign and cause different reactions like that. But the important thing is to kind of watching these dose adjustments. It's like, are we looking at higher and higher doses for these to receive kind of the same treatment benefit as that we had before.
Okay, 2 more questions and then we'll wrap it. They keep coming. Do you have any recommendation for urine or serum calcium or phosphate levels yearly, or just the typical urinary analysis and maybe creatinine?
So,
yes. You want to take that one, Rose?
Yeah, for our standpoint, I mean, most of the time patients are getting monitored anyway clinically and as well as lab work, but just getting a full panel with a calcium, a phos, and the urine studies as well as a vitamin D, I think is more than appropriate to kind of monitor any changes and be able to kind of act in a preventative way. You know, if the vitamin D levels start to lower, if there's an abnormal phosphorus, then kind of look into that before we see a symptom or before we see stones and other issues. You know, it's a blood test, nothing, you know, we do nothing like that we're going to harm a patient. We're not getting CT scans, you know, annually for stones or things like that, but they're already getting monitored or blood levels, and to add that once a year with a simple blood pressure check is a very kind of simple thing to do for a lot of prevention.
Sorry, I had an issue with my mute
Sorry.
button. The final question from a patient that she had kidney issues as a young girl, has had blood in her urine, but just at 56 years old was just diagnosed with HPP. Any recommendations on how to prevent further damage?
Yeah, so I think this issue of how frequently to measure blood test and whether to do urine test in a patient with HPP, we've talked about. We think once a year makes sense, and whether you do urine levels of calcium, for example, or not, I think is still somewhat controversial, but certainly in a patient that has kidney involvement or has nephrocalcinosis, then it is really important to be managing that on a regular basis. So for example, with chronic kidney disease, depending on the extent of the chronic kidney disease, you might be talking about getting labs once a year if it's mild, but if it's moderate or severe, you're talking about monitoring kidney function 2 or 3 times a year. And I would definitely be looking at those urine levels to you know, make sure that that is being optimized. And you know, I feel bad about that. I can tell you, so many of the kids we see with HPP, one of the parents was diagnosed late, you know, and sometimes we even get, I had one recently where the kid was diagnosed as a teenager, and that led to us diagnosing the parent, you know. So it does happen. And I think the best you can say is when you do make that diagnosis, all of you, the patient, the family, and the healthcare team are going to be wiser and have a better idea of what to look for and how to minimize unnecessary complications. So it is the pathway to getting better care.
Knowledge is everything, right?
Yes.
That's empowered.
Yes, absolutely.
Conversations. So with that, you know, I want to thank you so much, both Dr. Yube and Dr. Mann,